have a recording.
I think we are about to be in business.
I can see your screen.
Okay.
I can see your screen. So if we could just wait a few minutes for everyone to arrive.
Yeah, we should wait. Yes.
Good. Thank you. I'll let you know as people arrive here.
So, by the way, I have just acquired funding for a fellow next year.
Oh, wonderful. Congratulations.
Yeah. Well, unfortunately, I'm always missing one piece of it. There's no fellow.
Oh, okay. Well, there's a lot of people that are interested. If we can just get that out there, and
yeah. So if somebody is interested for July, I have money.
So the money's the first thing, and so send me the information, and I'll get it posted on our website.
Yeah, I mean it's basically just if they have it to call me or contact me.
Well, send me whatever you want to. Send me what you want to post.
Dr. Kawa, how can we reach you? Do you have contact information?
Yeah, so my contact, I'll give you two things. So my email is Joseph.Carver and the number 2 at uphs.upenn.edu. So Joseph.Carver2 at uphs.upenn.edu. And my cell phone is 484-716-3128.
Great. Thank you.
Okay. Hello, Joshua Mitchell just came on. Joan Kraft is here.
Josh, how are you?
I'm good. How are you?
Good.
Glad to have you here, Josh.
Yeah, good morning. Morning, Joe.
Good deal.
Morning. So I was on the elevator yesterday, and Jen Cronin goes, "How's Josh doing? Is he still here?"
That's got to be an in-joke.
Josh spent a month with us.
Okay. So, Joe, how do we connect? How do we connect the journal to ICOS? How do we do that, Joe?
So there is, I mean, I think that it's about to happen. So there's been ongoing discussions and there's agreement on both sides to do this. I think there's going to be, like a conference call.
Coming up soon, right? Coming up soon.
January
like the 26th.
And we got Dan. Hey, Dan, how are you?
I'm good. How are you guys?
Doing great.
Hello, Dan.
Hello.
Dan's leaving for Argentina pretty soon.
Yes.
Where are you going to be in Argentina, Dan?
Well, I was hoping to meet Messi because he's no longer playing in the Champions League, so I thought he'd be in Argentina.
Yeah, and where are you going to be there?
Buenos Aires.
Oh, okay, great. So you'll be in BA because my son-in-law is in Patagonia, and he goes in and out of BA. So I'll have to, I'll keep in touch with you while you're there.
Absolutely.
If he needs any help, we'll go to you.
Absolutely, and love to meet up with him if he
Yeah, we'll see
happens
if
to
we can
be.
make arrangements for you guys to have lunch or dinner or something.
Awesome.
Yes, we have Rachel Harris who just came in. She's our new fourth-year fellow starting in July. So we're really glad to have her here.
Excellent.
We have
Well,
Chiara Maloney.
yeah,
Hello,
We always.
Chiara. Hello, Chiara. Hello, Calvert. Hello, Michelle.
Yeah.
Hello.
Hello, Sebastian. How are you?
Hello, Eric. Hello, Eric. Hello, everybody.
Yeah, how are you?
hello, Sebastian.
How are you feeling? You were a little ill there for a while.
Now I feel better, but I have the dangerous pharyngitis. I
Oh
was
no.
very ill.
Well, you're welcome to come to Tampa to convalesce.
Great idea.
Take the cure in Tampa. Okay, it looks like we've got a pretty good group here. Joe, would you like to get started?
Yeah, sure. So thank you. I think this is going to be a little different than our usual case. So here we go. I just have to make.
So your slide is in black and white. Does that imply that your presentation is not going to be?
I think that it's probably a good deduction, Dan. All right, so let me just get rid. No, I don't want to leave the webinar. Okay. Okay, here we go. So this is a 50-year-old woman who has a past history of hypertension that was easily controlled with basically diet, who has had what she describes as palpitations for the last 30 years, never with any hemodynamic impact, and never actually documented with a diagnosis, and that's basically her prior cardiac history. She actually didn't come to me, but came to one of my colleagues after the following scenario. And for some reason, it's not advancing. So she had 2 episodes of that can be described as a TIA. It lasted less than a half hour, but with definite word finding difficulty, sensory numbness, and left upper extremity weakness. The first event was a couple months ago, and the second was a week ago. She had no associated pre-event symptoms and no post-event symptoms. And she had no awareness even of her prior underlying palpitation.
Joe, was she right-handed or left-handed?
Okay, so I don't know the answer to that question, but it's probably a reasonable question. We can assume that she's right-handed. Okay, no, 2 previous pregnancies without any incident. She's had no current constitutional symptoms, no history of any prior embolic or thrombotic event, and is not using any illicit drugs or substances. So this is an exam that's extracted from the emergency room record from the second event. Her blood pressure was 180/96, and from the standpoint of total exam, there was nothing that was really remarkable by, at least in the light of an emergency room physician examining somebody in that setting. This is her cardiogram. Dan, since you always ask me, you can.
Sinus rhythm, little non-specific ST wave changes in V1, 2, and 3. You could say poor R wave progression, although that's a pretty soft finding. So mainly.
So I think that nobody, to the point of evaluation, had ever even commented that they thought that this was abnormal, or just saying there was no comment about her ECG or whether there was any implication related to her event and the cardiogram. So it was sort of ignored. Okay, so she came with a whole bunch of prior studies that I'm going to overwhelm you with. So she had an MRI of the brain that you can read what's there. Typical radiology, throwing stuff in that to cover themselves, but basically there was nothing that was that jumped out other than these hypertense densities that nobody knew really what they were.
So
nothing.
Classic MRI bright spots.
Yeah. Nothing on the head CT. She had a carotid duplex study that was read as normal. An MRA of her neck, and you can see that there was some atherosclerotic stuff, but no major obstructive disease. And there was nothing on the MRA of the head that suggested any vascular abnormality. We saw the cardiogram at the time that she initially came. We had a report only of the echocardiogram that was unremarkable. Normal EF, normal wall motion, no valvular abnormality. And she had worn an event monitor for 1 week, and there was no documented atrial fib. And a lot of lab studies. So at the bottom, you can see that she had a hypercoagulable workup that included things that I never even knew existed, all of which were negative, I guess because of the MRI report. Somebody did a Lyme panel that was negative. She had blood cultures that were sterile, and all the other things that are there. And surprisingly, maybe not surprisingly, with no lipid-lowering medications and already atherosclerosis in her carotid arteries, she had an LDL of 75 and an HDL of 75. Any comments about I think that's all the workup stuff. Any comments about the workup evaluation to this point?
Yeah, I mean, certainly doesn't look like any kind of hypercoagulable state. She sounds pretty convincing for a TIA, so I think that part is convincing. And then you have these little white spots on the MRI. And when she presented to the emergency room, she was quite hypertensive. So I don't know if that just kind of came out of the blue, or if she had a history of hypertension that previously had not been treated.
Yeah, so with diet and by history, controlled. So as you know, different people have different concepts of what control is. And I'll leave it at that, right?
Was there plans for a transesophageal echo?
Okay, well, keep that in mind. So that up to this point, no. So somebody started nifedipine at 30 milligrams a day. Why? I'm not sure. That was the initial drug of choice. Maybe,
especially in a woman. I mean, they're gonna have edema in their ankles, and they're not gonna be happy about it.
It's like maybe the Pfizer representative left samples in the office that day or something. And then they titrated up to 60 milligrams in follow-up. She actually saw a renal hypertension specialist at an outside institution, and she saw neurology at HUP, and their combined wisdom was that this was a hypertensive urgency and that was the potential cause of her symptoms, kind of a little bit on the line of what Dan said. So what's the most likely cause of her symptoms and what additional studies do we need? So I think Eric already mentioned a TEE, which sounds logical. I mean, I would probably first get a disc of the original echo and look at it. But that's certainly a TE is a consideration. And I think that whether it's hypertension or it definitely sounds like a TIA. Any other comments?
I think if you had done a regular transthoracic echo, but you'd done a bubble study, that probably would have been useful.
Okay.
So Joe.
Agree. Yeah.
So sorry, my audio was messing up earlier on me, but it's good to hear from you again. I guess my one thought was the MRI read didn't really include embolic phenomena as the differential, although that's what many of us are thinking given that we're in a cardio-oncology conference. And did they comment at all on whether they thought that was likely or unlikely?
Say that again. What was unlikely?
How likely was it that the findings on the MRI were caused by an embolic phenomena as far as the radiologists were concerned? It didn't look like that was in their differential.
Yes, they were not that impressed.
So, Joe, in the carotid study, the ultrasound was normal, but the MRI said less than 50% obstruction by measurement. How do those reconcile?
Yeah, so I think, again, depending on technique, that probably the gold standard is still the MRA, I think, is a little bit more accurate. That
I would argue that may be true for percent of stenosis.
Yes, exactly right.
Screening for atherosclerosis, the ultrasound is going to be far better.
Oh yeah, I wouldn't as a screening test. So I should have just clarified that an abnormal carotid ultrasound and the declaration of percent stenosis may not be completely accurate, and that an arterial imaging study is probably more accurate for percent. What you said, Dan. Agree. But I think as a screening test, if it's normal, it generally is pretty reliable.
And certainly on the MRI, you can't see calcium, and so that makes it a little difficult with the MRI not being able to see calcium.
That, and also, I mean, you can, as a screen for atherosclerosis, you look at carotid internal medial thickness.
Right.
And
you
can't see any of that on an MRI. Or the MRA. But so if you're looking to try to define the degree of stenosis, an MRA is probably that, and a CT are equivalently good tests. But screening for atherosclerosis, there's really no comparison.
Yes, agree. And that I often use the intimal medial thickness as a referee in decision making. Okay,
So, and it sounds like based on all the studies that were done, she clearly has evidence of atherosclerosis, even
Yes.
though she didn't really have, much history. It doesn't sound like.
Yeah, and I think that the other piece is that nobody sort of pursued was that she does have an abnormal cardiogram. I mean, I probably would like to see another one and make sure that it wasn't just lead placement. But if she continued to have T-wave inversion out to V3, I mean, it probably, and atherosclerosis in her carotids, it probably warrants at least at some point making sure that she doesn't have the same stuff in her coronaries.
May I ask a question? I'm sorry.
No problem.
Don't be sorry. That's why we're here. Okay, Jared.
Okay. Hi, I'm Veronica from Brazil. It's a curious history, of course, and I'm thinking about that her symptoms started when she was a young person, in the teenage years. Yes.
Yeah, so she had,
yes,
quote,
she had
palpitation.
something in the palpitations and something like that. And I'm just wondering if we could think about her persistent foramen valley too, and the trosilophageal echo could show us. Maybe it could help in some way to explain some of the symptoms. I'm sorry if I'm saying something wrong. Thank you.
No, I think it's perfectly logical. I mean, I think that if anything, I think that there's a fine line in people who come in with palpitation about how much you should do to make a diagnosis or to say that it's benign and nothing. So I think that in retrospect, and which is always very good, that it would have been nice if somebody did some evaluation. So I'm not sure how she was ever if it was ever pursued, but I think in our everyday stuff, I mean, I often see people that have palpitation and it really doesn't sound like anything, and I'm not sure how much we have to do and to either reinforce what we think or to look for things that like a PFO. So we have time to pursue that question also. Dan or Josh, what do you guys think?
Yeah, I mean, I would say a complete transthoracic echo with bubbles would have been nice, but I certainly, I think people have done TEEs for less than this, and certainly wouldn't have any issue with doing a TEE.
Okay, so
there's a 35% correlation between carotid plaque and coronary plaque. 35% correlation.
Right. Yeah. So, yes, agree. So I think that at some point we would like to know if she has coronary disease. Okay. So somebody asked for a TE. She had a TE here. I hope that this shows up on your screen, but I put in a couple arrows so that's one image. I have a couple of images, and
yeah, so you see a little something there underneath the valve.
Yeah, so
that you're pointing out.
Yeah, so both at the aortic and mitral valve that there are, and in the CINA, that they're definitely mobile and they come in and out and they look a little bit better than on the still shots, but they're basically on both valves, small, highly mobile densities.
So are those Lambrow's excrescents, or are those Libman-Sachs type lesions?
You know, I would actually be most worried about a paraganglioma because, number one, this is a cardio-oncology presentation, but also because it's on the underside of the valve and it is associated with, embolic events in a very big way. So
yeah, and it's on two valves, so it's on the aortic and the mitral valve, right? Okay, so this is provocative, and somebody should be scratching their head and say, like, why is he doing this in a cardio-oncology presentation? So, after seeing this, the person, and I can't take credit, the person who saw her actually asked for discs of all the prior imaging stuff from the outside hospital, which they hadn't done before. And it turns out that there was on the MRI that there were a couple of nodules on the thyroid that nobody commented on. So the next thing that somebody did was a thyroid ultrasound, and there are, for those of us who don't see thyroid ultrasounds that much, I mean, multiple nodules on her thyroid. When biopsied, she had follicular carcinoma.
So she had, those are kind of true and unrelated. So, okay, so maybe not. No, those little spots on the valve are not thyroid cancer. No way.
Okay. Anybody else want to comment?
So what would be the options, Dan, in terms of evaluating those little things that we see that are little filamentous things that are on the valves, two of them?
Yeah, I think that, we just saw still frame images on the MRI, on the TEE. So I would hope that over the course of the actual TEE, you could see those a bit better.
Yeah.
Would those be the Landau's excrescences? Are they like Libman sac type lesions? What would you say about that? Are they on the right side? Are there any there?
Nothing on the right side.
Yeah, I think the most concerning diagnosis would be, like a papillary fibroelastoma or something like that, paraganglioma that exists underneath the valve. That is a rare condition, but it is highly associated with embolic events, and it has nothing to do with thyroid cancer. But
generally only on one valve. They're not usually multifocal like that.
Yeah, I've seen some reports on multiple valves, but they don't look like fibroelastomas.
Right. Right. On echo, fibroelastomas have a pretty characteristic. They're much more dense and homogeneous, and they're not this filamentous structure. So anyhow, this is a good discussion. Let me. Anybody else want to say anything before I go on?
Can I comment?
You can.
Yes, you can comment.
Sebastian from Poland, from Europe. Many thanks for this case, because we know that thromboembolic events may be the first sign of cancer diseases. But last year, our friends from Spain documented their own experiences that the patients after stroke may be diagnosed with cancer disease after a few months. So from last year, we know from our friends, specialists of neurology, that patients our TIA or stroke maybe experience cancer diseases, especially lung cancer and prostate cancer, hematological malignancies, and you have documented that thyroid cancer may be the same reason of TIA. Many thanks for this case.
So I think certainly with the concern for embolic phenomena and thyroid cancer, and maybe they're unrelated or maybe they're related, you'd be concerned for either metastatic thyroid or thrombosis in the heart. And I guess my question for you, Dan, would be, why are you so sure it's not thyroid? Like, because it does not classically look like a papillary fibroblastoma. I don't know what it classically looks like, and so I don't know how you can differentiate further from that. Do you have anything in particular that you know that it's not metastasis versus thrombosis, et cetera?
That's just not the metastasis pattern for thyroid cancer, and then follicular carcinoma is not very aggressive, so that doesn't seem even remotely possible. You would you would have to have a lot of intrathoracic metastatic disease from your thyroid in order to get anything in your heart. So I don't think those are related at all, but I think something funky is on those valves, and with the MRI that was clearly abnormal, you know, how do you reconcile those things? I don't know. This is a tough call.
Yeah, so I agree, Dan. I agree 100% that those are not metastatic lesions. Period. I mean, that would be an unusual appearance of metastases from breast, lung, prostate, anything, and clearly
that would be
if you like right, and melanoma, which goes to the heart a lot, doesn't present like that. I mean, it presents in a different way. Renal cell, so all the things that typically can go to the heart look different, and to say that this was metastatic thyroid cancer would be like below the bottom of the list, probably. I agree with you. Okay, but so the reason that I thought that we should talk about this is that I don't think that we think about this enough in the cancer population. So non-bacterial thrombotic endocarditis is a well-described entity. It's been at least characterized by multiple different names, from, I think in the old days, Morantic endocarditis, Liebman-Sachs, which is typically associated with lupus and with other rheumatologic connective tissue diseases, but that they look the same. It's just that the association with lupus is ascribed to Liebman and Sachs. And then people have also talked about verrucous endocarditis. So this entity does exist. It's not where the cultures are negative for a long time, because it's like some bizarre organism that they either can't identify or takes a long time to grow. So it's clearly culture negative endocarditis. So in autopsy series, there's a wide range, but depending on how people are looking for it, it can involve mostly valves on the left side, but there's a high association with malignancy, and we already talked about lupus, and then the hypercoagulable states make up the next piece of it. There are people who have reported it being as high as 4% in all end-stage cancer patients. And as I think Sebastian commented, that the cancers that he described are mostly adenocarcinoma, and everybody knows that mucin producing pancreatic cancer has a really high incidence of thrombotic events on the arterial and the venous side. So generally areas of high turbulence, which these certainly fit into that category, they can occur on normal valves, on the apparatus, and even the endocardial, so that you don't have to have an abnormal valve to be the nidus for this to begin. And because there's less inflammatory response than in bacterial endocarditis, that these lesions are clearly prone to breaking off and causing embolic symptoms in multiple different places. So the pathology is not much different, or the pathogenesis is not that much different than everything else that we talk about in cardiology. There's endothelial cell injury in the presence of some hypercoagulability, whether it's antiphospholipid or other syndrome like that, or what things that are associated with hypercoagulability in cancer. And oftentimes that, I mean, we all learned when somebody presents with an unprovoked VTE that you at least think that there might be an underlying cancer. I think that thinking may have diminished a little over time, but it's still in the background. But what happens is cytokines are released, and there's more damage, and you ultimately get platelet deposition, and these things now intertwine with the hypercoagulability to cause a friable, easily dislodged lesion. And I don't know how well this shows up, but at the arrow, you can see the same sort of subvalvular stuff that we talked about. So for the most part, they're clinically silent until they take off, and then they can go up or down, and including, I think in the cancer population, I'm particularly intrigued when we see somebody that has big time cancer being treated in the hospital, and we get called because they have chest pain, and they make some troponin, and they've never had coronary disease, and we always sort of explain it by saying it's demand ischemia, but I think that sometimes it turns out that it's embolic stuff that we probably miss, so that we should try to keep that in the back of our thinking. The classic things that you see with bacterial endocarditis are generally absent, so people don't have to have a murmur, and these things don't cause enough hemodynamic turbulence to be audible, and other than fever that they may have from their underlying disease, that it's not really a feature of the disease. There's no confirmatory lab tests. It's by inference and deduction, and clearly the best diagnostic tool is probably the transesophageal echo in the presence of negative blood cultures and some evaluation, if it's not obvious, to look for hypercoagulability, and that if you don't find any of those things and the person doesn't have lupus, that you should look for the common adeno-type cancers. So breast cancer in women, lung cancer, and definitely prostate and pancreas. From the standpoint of management, it's a little bit controversial. There's probably not enough. There's definitely no controlled studies that talk about anything but treating the underlying disease. The big question is how long should people be anticoagulated? And it turns out that at least in the past literature, that unfractionated heparin has fewer complications and more effective than warfarin, probably because the latter is probably a lot of times subtherapeutic or supratherapeutic, and that the novel anticoagulants, oral anticoagulants, have not been evaluated, and there were people who have tried steroids for this, and there's no proven role or any proven benefit for steroids. And then obviously, if these things are more dynamic than in this patient, and there's valvular dysfunction, that there is an indication for thoracic surgery intervention. So non-bacterial thrombotic endocarditis is non-infectious, and I think that even though it's rare in the general population, that I think that it's probably out there much more than we recognize in the care of the people that we take care of, and that remember that there is an association with malignancy. I'm not sure it has. If we make the leap and say thyroid cancer and this is related, not as a metastatic disease, but as an environmental association, maybe it occurs before disease is particularly advanced, and obviously if you find it and you go on a tumor hunt, it doesn't have to be major league advancement of the malignancy, lupus and hypercoagulability, and that in the absence of embolic issue or severe valvular dysfunction, that patients are asymptomatic, and we're asymptomatic in diagnosing it, so that we should maintain at least a level of suspicion as we approach people who have embolic disease, and not. I mean, I think that we always fall into the trap of this is atrial fib, and we have to do long-term monitoring to find atrial fib. But the answer is that when it is an atrial fib, that we ought to look for this, and long-term anticoagulation is basically the treatment. So she had the thyroidectomy that you saw. Planned for her to get I-131. Her blood pressure was controlled, so the person who saw her didn't change her nifedipine. She was anticoagulated with Lovenox, and at least up until I checked with them the other day, that no further embolic events. I'm not sure that they've actually pursued anything looking for coronary disease. So I just thought that this was a little bit different than what we normally do, and a little, it's certainly in our realm, and that I know personally that I don't think of this before this case as much as I probably should. So,
this is a beautiful case, Joe. Unbelievable. But I would still say that and I would agree that you should anticoagulate this patient for the time being, whether you chose enoxaparin or factor 10A inhibitor, or whichever one you chose, is you're kind of just making it up or taking whichever one you like. I think all of them are probably indicated at this point, but that I would also include aspirin, so you'd have to have the patient taking an aspirin. But I still think that I'm not sure these two things are related. I agree with you, and I think that a cardiac MRI at this point might be able to demonstrate the funny little things on the valves a little bit better. But either way, I would say you probably want to repeat some of these studies in a couple of months to see if those valvular lesions change in any way. Because I really think that those, you know, the people that I've seen in the past that had merantic endocarditis or whatever, however you want to refer to it, they usually have extensive cancer. And, you know, this is papillary thyroid cancer is not extensive cancer. That is localized.
Yeah, so I mean, if I was involved, I would probably get a CT of her abdomen and see if there was anything growing on her kidney, or if there was any abnormality in her pancreas. And I don't know what her mammogram status is, but clearly if she's not up to date, that she should clearly have a mammogram and a GYN exam if she's not, you know, up to date in those things. So I agree that the sort of the simple passing it off explanation, starting with hypertensive urgency to it's because of her thyroid, is probably, I think, a little too simple. And I think that there might be more to come.
Excuse me again. May I ask a question? Hi, it's me again. What's the explanation for the symptoms in the young age? Because the history starts telling us that something happened, palpitations and something like flutter when she was a teenager and so on. So I'm quite worried about it. So what's the explanation for that? Thank you.
So I would say that that she had an awareness of her heartbeat. She may have had isolated APCs or VPD or ventricular stuff that everybody has, and that she just has a good internal monitoring system and recognized it. I mean, I don't think, at least other than these lesions that we saw in the valve, that there's structurally nothing that sort of jumps out from somebody for 30 years that caused a problem. Yeah, so I think it's a good question. At least it deserves thinking about and asking and looking for an answer. But I don't think that that it was anything that somebody missed over the last 30 years. But it's definitely a good question.
Yeah, I think this is a great case, great discussion. Really appreciate you bringing it up, and it's definitely an active issue. I mean, we just had a patient that presented with mental status changes and ultimately was found to have, leukemia type cancer, and we argued to put them on factor 10A inhibitor. So I think that this is a very real issue, no doubt.
Yeah, so I can't imagine that a 50-year-old person is going to take two injections of enoxaparin for the next 30 years. Right? It makes no sense at all. So I would think that at some point that there should be transition to one of the NOACs, and then some decision down the line about how long you actually have to do that. But there's more to come for her, definitely. So the other comment that I would make is that the person who did the TE is the most meticulous person that I've ever met, and probably the TE took an hour, and I would say that in the majority of places, those things might have been missed.
Well, and I think that, you know, you may have just been at the very leading edge of those little spots, and, you know, they caused an embolic event. You know, given a bit of time, 3 to 6 months or something like that, they may change.
Yes. So I would just say two final comments. The first is that it's like a mantra of not accepting what anybody tells you in a report, and that you have to look at stuff yourself, and recognizing that a coronary CTA or an echo or a TEE, it's not the same every place in the world, and to recognize that in digesting information from the past when you see a new patient. And
unfortunately, we
keep this Morantic thing. Yeah,
the studies all the time because we have better equipment, or we don't like what we saw, or whatever. Seems like we run up a lot of costs, but we have to repeat the studies all the time. People have 9-year-old equipment of echo machines, and they don't have the specificity to be able to see all this fine, high-resolution stuff, and so we got to repeat it.
Yeah, and it's also, that for everybody on the phone, it's not only the equipment, but it's the people, the Eric Harrisons who are doing this versus other people. So in the absence of in 9-year-old equipment, I would still rather hear what you had to say and what you would do with it than somebody in a community hospital that reads CTAs once a month, right?
So we call that the Millennium Falcon syndrome. And basically, if you got the Otis Starship in the Empire, but you've got Han Solo and you got Chewbacca, you can outfly everybody.
All right. Well, I always thought you looked a little like Chewbacca. Okay, that's all I got, guys.
That's
Thanks,
right.
Joe. That's a great case.
All right. Thanks a lot.
Thank you so much.
Okay.
We really appreciate this, Joe. It was a really great case selection to keep everybody on their toes. And so we really appreciate that. Thank you very much for your attendance, Calvert, Chiari, Cindy, Dana, Dan, of course, Holly, Joan Kraft is here, Joshua, Liling, Maria, Michelle, Roizen, Sebastian, of course, Thelma, and Dr. Ping. Thank you so much. Guys,
Thank you.
have a great month.
Okay, guys.
Look forward to talking.
Thank you. Wonderful case.
Great case.
Great pleasure.
Always
Thank
learning.
you, guys.
Thank you.
Okay.
Enjoyed
Bye.
very much.
Thank you. Congratulations.
Bye-bye.
They see you.